Hello everyone, my name is Hannah Wrench. I'm a paramedic with Cumming County EMS. Today I'm going to give a presentation on mental and behavioral health. So let's get started. What is a mental illness? So mental illness is a health issue that is sometimes missed due to lack of visible symptoms or signs. So it's not something that you can see, it's something that's internal. It can affect one's thoughts, mood, or behavior. It can also be short-term or it can be a long-term, lifelong thing. Mental illness can affect one's quality of life or interfere with their daily activities. So there's different types of mental illnesses. One type of mental illness is mood disorders. A mood disorder is also known as affective disorder, and it affects one's emotional state. Common mood disorders are bipolar disorder, which is a severe disorder that causes periods of extreme excitement followed by periods of extreme depression. So it's from one extreme to the other. There's major depressive disorder, which is also referred to as clinical depression. It's a disorder that affects one's emotional well-being, their thoughts, and their daily functioning. Cyclothymia, I may be saying that wrong, is a mild mood disorder that causes mood swings, depression, and hypomania. Hypomania is a less severe condition than mania. However, it causes elevated mood, increased activity, decreased need for sleep, and racing thoughts. So mood disorders continued. We also have DMDD, which is also called disruptive mood dysregulation disorder. It's a persistent irritation or ill mood with frequent outbursts. We have persistent depressive disorder, dysthymia, which is chronic depression, however, is less severe than clinical depression. Premenstrual dysphoric disorder, PMDD, it's depression and mood changes that begin approximately 1 to 2 weeks before the menstrual cycle starts, so during the menses, and the symptoms cease once the cycle begins. Postpartum depression is another type of mood disorder. It causes fear, anxiety, mood swings, and excessive crying. It happens after delivery of the baby and usually lasts up to a year max. We have psychotic disorders. This is another type of mental illness. Psychotic disorders affect the ability to make good judgments, think clearly, respond emotionally, communicate well, behave appropriately, or understand reality. Some types of psychotic disorders include schizophrenia. Schizophrenia is characterized by behavior changes such as delusions, hallucinations, and they last long for about 6 months or so. Schizoaffective disorder, characteristics of both schizophrenia and a mood disorder, such as bipolar and depression symptoms. So it's a little bit of both. You have symptoms of schizophrenia, but you have symptoms of bipolar as well. Schizophreniform disorder, symptoms of schizophrenia with symptoms lasting only 1 to 6 months. So it's not more of a long term, it's just more acute than schizophrenia itself. So here's the psychotic disorders continued. So brief psychotic disorder is a sudden short period of psychotic behavior. It happens after a stressful or difficult event, such as a death in the family. It resolves usually in less than a month. We have delusional disorder. It's a delusion, which is a fixed or false belief. It involves a real-life situation that is possible to be true, however, is not true. So, for example, the patient thinks that they're being stalked when they're really not. They feel like they're sick, however, they're not. They feel like they're being abused when they're actually not. So it lasts for around a month, tops. We also have shared psychotic disorder. So it's when two people in a relationship, one person in the relationship has a delusion, and then their significant other adopts it as well. So their significant other starts to believe the same thing when it's not true. They also have substance-induced psychotic disorder, which is hallucinations, confusion, or delusions that are caused by drug use or withdrawal. Usually crack cocaine or hallucinogens are involved. So psychotic disorders continued. We have paraphrenia, which are symptoms similar to those in schizophrenia or delusional disorders, and is noted in elderly. and caused by neurological problems. So like patients with dementia or Alzheimer's. There's psychotic disorders that are also caused by other medical conditions. So it can be caused by head injury or a brain tumor, and then it could cause the patients to have hallucinations or delusions. So they were totally fine before the head injury or the tumor, and then now they're having hallucinations, they're having delusions, they're just not their self. So next we have trauma-related disorders. That's another type of mental illness, and there are different types of trauma-related disorders. So we have PTSD, which is post-traumatic stress disorder. We have reactive attachment disorder, known as RAD, disinhibited social engagement disorder, DSED, acute stress disorder, ASD, adjustment disorder, or unspecified trauma and stressor-related disorder. So traumatic events can also cause anxiety, depression, substance abuse, personality disorders, or dissociative disorders as well. So trauma-related disorders continued. Trauma-related disorders come from a state of being overwhelmed. Trauma-related disorders can come from events such as combat, natural disasters, death, abuse, injury, or assault, commonly seen in military, first responders, children, older adults, or subjects with economic stress or developmental disorders. Main symptoms of trauma-related disorders include dysphoria, which is dissatisfaction or unhappiness, anhedonia, sorry if I'm not pronouncing these words correctly, decreased ability to experience pleasure, anger or aggression, dissociation. Other symptoms include fear, sadness, shame, nervousness, hypervigilance, insomnia, nightmares, self-harm, avoidance, muscle tension, or intrusive thoughts. So another type of mental illness is anxiety disorders. The different types of anxiety disorders include generalized anxiety disorder, which is characterized by extreme worrying or nervousness with little to no reason. It can be about health problems, family, friends, money, etc. We have panic disorder, which is frequent unexplained panic attacks that are caused by sudden fear or feelings of loss of control. We have phobias, which is continuous, uncontrollable, irrational fear. Can be a phobia of a certain object, place, or activity. Examples include agoraphobia, which is a fear of small spaces, or acrophobia, which is a fear of heights. We also have social anxiety disorder. So this is a fear of participating in social situations, which can cause nervousness, sweating, blushing, rapid heart rate, so racing heart rate, chest pain, and this normally happens around a large group of people. So these are your people that aren't a big fan of going out to the mall or a concert or even a birthday party where there may be a lot of people or a lot of noise. We have separation anxiety disorder. It's the anxiety of prolonged separation, which can cause panic attacks and interfere with daily activities. And a lot of times you do see this in mother after delivery of baby. So may also have some postpartum going on. However, also has that separation anxiety disorder where she's anxious from leaving the baby. So we see that a lot in our patients after they give birth. Selective mutism, which is an anxiety disorder as well, and it makes one unable to speak during certain situations. So when they get very anxious, they become actually unable to speak. So we also have eating disorders. So another type of mental health disorder is eating disorders. Eating disorders are psychological conditions that cause unhealthy eating habits. A few types of eating disorders include anorexia nervosa. It's a condition in which someone views themselves as overweight when they are actually underweight. They avoid eating certain types of food and excessively exercising. They weigh themselves constantly and count calories to avoid any weight gain. We also have bulimia nervosa, which is more common in women than in men, and most common in adolescence and early adulthood. The individual binge eats a large amount of food and is able to control the amount, so they feel that they have no control. And it's normally a type of food that they would try to avoid, like sweets or fast food. When they become uncomfortably full, they try to purge to ease gut discomfort and compensate for the calories that they used. So normally they purge the food by inducing vomiting, using laxative or diuretics, fasting, using enemas, or continuous heavy exercise. So this is our eating disorders continued. We have binge eating, which is the most prevalent eating disorder and is most commonly cause of chronic illnesses in adolescents. So this also affects our younger folks. They eat a large amount of foods in a short period of time and just feel a lack of control. And it's normally, again, foods that they normally would try to avoid, like fast food, sweets. They do not try to purge the food later, however. So that's the difference between the two. Last but not least is pica. Pica is eating objects that are not considered food and do not have nutritional value. So they crave food, non-food items such as ice, dirt, paper, hair, laundry detergent, cornstarch, etc. Sometimes seen in patients with schizophrenia, autism, or other cognitive or developmental disabilities, and it poses a risk of infections, poisoning, or choking. So next is substance abuse disorders. This is another type of mental illness. Types of substance abuse disorders include opioid use disorder. Commonly abused opiates are fentanyl, heroin, Percocet, etc. Marijuana use disorder, nicotine use disorder, stimulant use disorder such as cocaine, amphetamines, sedative use disorder such as Xanax, Valium, Ativan, Furosec, hallucinogen use disorder such as LSD, MDMA, hallucinogenic mushrooms, and alcohol use disorder, beer, wine, liquor. Substance abuse disorders are continued here. We have a common risk of substance abuse disorders are overdose and death. In the U.S. in 2020, there were 68,630 reported deaths due to overdose. In 2021, there were 80,411. So the numbers unfortunately kept increasing. Overdoses can be accidental or they can be intentional as well. So here are causes of mental illness. So there are a lot of different causes here, as you can see. We have genetic factors, which could be a family history of mental illness. So it can increase your chance. Just because your family member has a mental illness does not mean that you definitely will have it. It just increases the chance of inheriting it. We also have drug or alcohol abuse. Drug use can trigger manic episodes in bipolar disorder. Cocaine, marijuana, or amphetamines can cause paranoia as well. We have biological factors. Some medical conditions or hormone changes are biological factors. We have early life environment, so negative childhood experiences such as child abuse or neglect could lead to a possibility of these mental illnesses. Trauma and stress, traumatic events such as exposure to a war zone, social isolation, domestic violence, relationship issues, financial or work problems. We have personality factors. Perfectionism or low self-esteem can also increase the risk of anxiety or depression. So treatment for mental health. You can seek help at a psychiatrist, a psychologist. Psychiatrist is a medical doctor in which can prescribe medications if necessary. I know I often get these two confused because they are very close in wording. Psychologists, on the other hand, are certified. However, they are not doctors, but they provide treatment more in terms of therapy. And there are a lot of different types of therapy for mental health, thankfully. So the different types of therapy include supportive psychotherapy, cognitive behavior therapy, psychodynamic therapy, interpersonal therapy, and acceptance and commitment therapy. So types of therapies explained. So first up, there is supported psychotherapy. It focuses on providing emotional support, encouragement, and validation. So this is the one when we think of therapy, when we think of going in and talking to a doctor. This is normally the one that we hear more about commonly. So encouragement, validation can be during difficult life circumstances like divorce, a death in the family, or psychological changes. Encouraged to talk about one's feelings, and they have no judgment. So they are encouraged to talk, and the provider does not judge them for it and gives them advice. We have cognitive behavior therapy, which is a psychosocial intervention. It works to reduce the symptoms of multiple different types of mental health conditions. We have psychodynamic therapy. It focuses on unconscious processes to help give self-awareness and understanding how past experiences influence current behavior. Interpersonal therapy is next up. It focuses on relieving symptoms by improving interpersonal functioning. It addresses current issues rather than past issues. We have acceptance and commitment therapy, mindful psychotherapy that helps one focus on the current issues and accept their feelings and thoughts. So treatment for mental health continued. Another type of treatment for mental health is lifestyle changes. These are changes that the subject can make in their own life to help their mental health. So it's not something that will completely fix it. However, it's something that can help continue to decrease the problem. So exercise is known to prevent and ease anxiety and depression. So it's great after a very long day of work or a stressful day in general. You can go out, get a good jog in. It's known to help decrease anxiety. A healthy diet, eating good, feeling good, social support, surrounding yourself with someone that supports you and does not judge you is very important. Avoiding illegal drugs and alcohol, like we discussed, schizophrenia does not do well with drugs. So cocaine, amphetamines makes the symptoms a lot worse. So the patient avoiding the illegal drug and alcohol use helps a lot with improvement in their symptoms. The treatment for mental health continued. Another treatment for mental health, which is greatly used, is medication therapy. And this is what we see a lot. I know we see a lot of different medications on the truck. So these are the different classes of these medications. So there are a lot of different types which are used to treat different types of mental health disorders. So first up is antidepressants. Antidepressant is a class of medication that is used to treat major depressive disorder, anxiety disorder, addiction, or even chronic pain. Common types of antidepressants are SSRI drugs, also known as selective serotonin reuptake inhibitors, such as Prozac, Paxil, Zoloft, Celexa, or Lexapro. So I know we see these a lot with our patients that have clinical depression or anxiety. We have SNRIs, which are also known as serotonin and norepinephrine reuptake inhibitors, such as Prozac, Paxil, Zoloft, which is also known as sertraline, Celexa, or Lexapro. We have SNRIs, which are also known as serotonin and norepinephrine reuptake inhibitors, such as Cymbalta, Effexor XR, Pristiq, or Fetzima. We then have atypical antidepressants known as Trazodone, Remeron, Trintellix, Vibrid, Forfivo XL, or Wellbutrin. Tricyclic antidepressants, or TCA, known as imipramine, nortriptyline, amitriptyline, doxepin, or norpinephrine. Again, sorry if I'm pronouncing these wrong. We have MAOIs, also known as monoamine oxidase inhibitors, such as Parnate, Nardil, or Marplan. The provider may also combine two different antidepressants, which is called augmentation. So that's when they use two different types of antidepressants and they coincide and help reduce the patient's symptoms. So medication therapy continued. Another class of medication therapy is mood stabilizers. These are used to commonly treat bipolar disorder by helping to reduce mood swings and prevent manic and depressive episodes. They are also used to treat hypomania, severe depression, and schizoaffective disorder. Some of the following mood stabilizers include lithium, which is a mood stabilizing medication prescribed as lithium carbonate, also known as Camcolit, Priadel, or Liscanum, or lithium citrate, LI liquid, also known as. We have our anticonvulsants. They also provide mood stabilization. So these are medications that are not just prescribed for seizures, which I found this really interesting. It's also prescribed as a mood stabilizer. So it doesn't prevent just seizures. It can help with patients that are bipolar, schizophrenic, which is really neat. Some include Tegretol, Lamictal, Depakote, or Epilim. We have our antipsychotics, which can also be used as mood stabilizers, and they are also part treatment for bipolar disorder. Some include Haldol or haloperidol, olanzapine, also known as Zolasta, Zyprexa, or Zipidera. We have quetiapine, which is known as Seroquel, Atralac, Bequel, Zaleron, or other various names. This one had a lot of different names as well. And then we have Risperidone or Respiridol. So medication therapy continued. We have our antipsychotic medications. They're a class of their own used for schizophrenia, schizoaffective disorder, bipolar disorder, mania, major depressive disorder, delusional disorder, severe agitation or borderline personality disorder, also dementia, delirium, or substance-induced psychotic disorder. Can also be one of the types of treatments for other disorders such as Tourette syndrome, Huntington's disease, Parkinson's disease, Lesch-Nyman syndrome, or OCD, which is obsessive compulsive disorder. There are two main types of antipsychotic medications. There's first generation antipsychotics, which are called typical, and they are the first types that were developed. So there's a lot of the older medications. And then we have our second generation, which are our newer antipsychotics. They're called our atypical. And they are now the main drugs that are used because they cause a lot fewer side effects than the first ones did. So typical antipsychotics include chlorpromazine, which is no longer available in the U.S. However, you can get generic versions of it. Fluphenazine, which is again no longer available in the U.S., but you can get generics. We have haloperidol, loxapine, melinodone, perfenazine, which is no longer available, pimozide, chlorpyrazine, compazine, dioxazine, deoxyridine, and trifluoperazine. We have atypical antipsychotics, which are aripiprazole, Abilify, acinapin, brexpiprazole, carbamazepine, clozapine, loperamide, Latuda, Seroquel, Risperidone, Geodon, and then we have a couple more. So these are the general side effects for psychiatric medications. The side effects differ between each drug class and each medication. However, these are some of the general side effects that you will usually see. So you have the less severe, which is the drowsiness, dizziness, dry mouth, blurred vision, tiredness, nausea or GI upset, constipation, weight gain, or even weight loss. It just differs on the person. Difficulty sleeping, anxiety, agitation, jitteriness, drooling, trouble swallowing, restlessness, shaking, stiffness, headaches, or loss of sex drive. So serious side effects, on the other hand, which are rare, however, require immediate attention, such as pounding or irregular heartbeat, seizures, confusion, or suicidal thoughts or actions. So these are the side effects that aren't seen as frequently. However, if the patient does experience these, we need to get medical attention right away. And it's also important to add that if the patient is experiencing a mild side effect, not to completely just stop the medication without telling the doctor right away. So to let the doctor know right away, and then they may have them stop it or may have them slowly taper it down, because a lot of these medications you do not want to just stop taking cold turkey. So next we have mental health and suicide. There are very serious symptoms of mental health emergencies such as suicide or homicidal thoughts. Suicide is one of the leading causes of death in the U.S. We're getting very serious here. In the U.S., in 2021, there were 48,183 deaths by suicide. That is one death every 11 minutes. And this was in 2021. So I cannot imagine, unfortunately, what the statistics are to the state. In 2021, 12 million adults seriously thought about committing suicide. 3.5 million adults made a plan, and 1.7 million adults actually attempted the suicide. In the U.S. in 2022, there were 49,449 deaths by suicide. In 2021, 38,358 of those deaths were males. In 2022, 39,255 men committed suicide. So it was seen more commonly in males than it was females. The race with the highest suicide rates in both years were Caucasian. In 2021, 36,681 Caucasians committed suicide. In 2022, 37,459 committed suicide. The lowest race to commit suicide was Native Hawaiian or Pacific Islander. In 2021, 82 committed suicide, and in 2022, 95 committed suicide. The highest age group to commit suicide was the 25 to 44-year-old group. In 2021, 16,724 subjects committed suicide. In 2022, 16,843 committed suicide. So the numbers, again, were increasing. The lowest group was the 10 to 24-year-old. In 2021, there were still 7,126. So these are our lowest numbers. However, they are very high numbers still. In 2022, 6,529 committed suicide in that age group. And again, that was the 10 to 24-year-old group. Firearms were more used than 50% of suicides. So 50% of suicides were committed by firearms. Suffocation was 26%. Poisoning was 12%. And then other means is 8%. So continued, suicidal feelings can affect anyone, any age, any gender, race, background, at any time. Common causes of suicidal thoughts are mental health problems. So someone with chronic pain as well, or a long-term illness, someone with cancer, or someone that is bedridden. Subjects that are bullied, and this is seen a lot in our youth, unfortunately. In school, there are so many children that are getting bullied, and that leads to a high risk of suicides in young children. Domestic abuse, sexual abuse, or physical abuse, bereavement, so death of a loved one, close family member, friend, the end of a relationship, so a divorce, isolation or loneliness, money problems, homelessness or other housing problems, difficulty adjusting to life changes such as retirement or redundancy, so feel like you're just stuck in the same job, the same thing every single day. Addiction, substance abuse, incarceration, so being in prison, pregnancy or childbirth, also postnatal depression, like we talked about, doubts about sexual or gender identity, cultural pressures such as forced marriage, so in other countries where there's arranged marriages, there's been people known to commit suicide because they have not wanted to marry that person, and then other types of trauma. So some medications can also cause suicidal thoughts as well, like we discussed. So here's our suicidal prevention for first responders. First responders are at an increased risk for suicide and are more likely to die by suicide than in the line of duty. In the statistics, it was saying that EMS responders are more likely to die by suicide than the general public. Telecommunicators are also at risk, so your 911 dispatchers or call takers. Nearly 1/4 of the dispatchers suffer from depression or symptoms of PTSD. Goals to find ways to weather stress of the job so first responders can live healthier lives and enjoy their lives and jobs more. We want to do this to increase their quality of life, but also to keep them at the job that they love doing and to reduce the turnover rate. Ways to prevent suicide or depression in first responders is to talk about mental health, talk about it among the first responders, and overcome the stigma of talking about it, because normally it's something that we don't want to talk about, something we want to keep inside. We go to a rough call and we just put it down deep. We go to another rough call, we put it down. And when you continue to suppress those thoughts, that's when the depression and the anger and anxiety builds up, and we don't want that to happen. So that's why it's important to talk to others. There's a lot of resources available in your workplace. I know our workplace in specific has wonderful resources, as well as with the hospital. We have our peer support team, so that is our peers, like it says. It's our coworkers, our friends that we already trust. We have all their phone numbers listed on multiple places in our EMS base. We can call them at any time if we need to speak to them, and they are also trained on how to respond and how to help us, and they know all the resources of how to help us. We also have the Employee Assistance Program, like I was saying with the hospital. It's EAP. We can go to them anytime. They have psychologists that can sit with us, that can help us, give us time off if we need to, hook us up with resources that we need, whatever it may be. We can take leave to get a mental break, have debriefings after difficult calls. I know recently did that not too long ago. It was very helpful. Everyone sat in and talked about what happened, just gave everybody encouragement. Everyone was able to talk freely and just kind of decompress after the call and come to the current terms that we did everything that we could. And I feel like that helped a lot. And that's very, very important. So debriefings after difficult calls. So after you have a pediatric call with a unwanted outcome, you have a mass casualty event, you have a wreck with multiple patients that is very serious, a fire with casualties. Anytime it's anything severe like that, it's very important for not just the EMS agency, but all of the responders around to come together. And again, that's another thing that our workplace and county does really awesome at, is coming together after there's a significant fire or a wreck. Like I was saying, they bring everybody together. They bring the fire department together. They bring EMS. They bring dispatch. They bring everyone involved to come together and to just discuss what happened and to work through it and be together. So being supportive, checking on each other after difficult calls is very important. Again, our coworkers, when we hear that dispatch and we know that that crew went to something difficult, that went to a pediatric, that went to just something very difficult, we can check on them. Again, we're not giving patient information. We're not doing anything like that. We're just saying, hey, are you okay? If you need something, you talk to me, I'm here for you. So that's very important. Also, just allowing a small break after difficult calls before going back into service, because you never know what your next call is going to be. It could be something very difficult, or it just could be a normal call, but you have to put on that smiley face and your positive attitude, and sometimes it's just hard to do. So they give you a second to, take a break. Call a loved one on the phone, talk to them, check on your kids. Talk to your coworker or your friend for a second. Go get something to drink upstairs. Go get a cup of coffee. I know a cup of coffee always helps me, and being able to talk to my loved ones on the phone. So just taking a small breather, enjoying some fresh air for a second outside the hospital before you go back in service, and then you feel like your head is clear and you're able to be 100% involved with your next call and with your next patient, and provide the best patient care possible. So just making sure that we stick together and check on each other is very important. So you're not alone. There are multiple resources and avenues to take to prevent suicide, such as predictive strategies for individuals, families, communities. It's very important to learn the warning signs and promoting prevention and resilience, also committing to social change. So to learn those warning signs, learn that not just a coworker, but a family, a friend, somebody, when they're not acting their normal, when you can tell they're depressed, talk to them, reach out to them, check on them, because they may feel like they don't have anybody. So just let them know that you are there. I feel like that's the most important thing. And it's something simple. We can pick up the phone and say, how are you doing? I was thinking about you. I was worried about you. Is there anything I can do for you? Learning about healthy ways to cope with stress and getting the right care and support to reduce further stress is very crucial. Sorry, I'm having trouble with words still tonight. So like I said, exercise, getting out after a long shift. There's still some daylight. Go for a jog, enjoy some fresh air. If there's not daylight left, then you go to the gym, get on the treadmill, blast some good music, and just get all that stress from that shift out. And I feel like that helps a lot. Eat a good diet. I know in EMS, sometimes we don't have the best diet. Sometimes we have coffee for breakfast, lunch, and dinner. And then we have a old Twinkie out of the vending machine at the hospital. And that's not quite a 3-meal kind of day, so we need carbs, we need fuel for our body. We're going to a lot of difficult calls. I know it's starting to get hot outside. We need to take care of ourselves. We need to make sure we're drinking water with the coffee to water that coffee down a little bit. We need to actually eat something nutritional, so our bellies are full, our minds are full, and we're ready to take on the next call in the next shift. So we also have suicide and crisis lines. They're available 24 hours, 7 days a week. So anytime. If it's 3 o'clock in the morning, the person can pick up their phone and make a call. They can also text, they can chat online, and there's online resources on the website as well. So that is contacted by 988 is all the patient has to dial, 988, and they get someone to help them and give them the resources that they need. So for veterans specific, there's also a veterans crisis line, and I know you see that posted a lot at the VA hospitals. They're really good at spreading the word for the veteran crisis line. It's another line that's open 24 hours, 7 days a week, anytime. They can dial 988, then press 1. So 1 gets them to the veteran side. They also can text 838-255. So other resources, such as Triangle Survivors of Suicide, there is Stop Soldier Suicide, Real Crisis Center, Hope Line, NAMI, North Carolina, and calling 911 is another way to get immediate help. So the most important thing is for us to ensure that others know that they are important and that they are cared about. Like I said, we went over a lot of different information today, and this is more mental and behavioral crisis. However, we also go to the emergencies as well. So to also cover, we have our local protocols, I know everyone follows different protocols, but for our local protocol, if we were to be dispatched to a patient that has a psychiatric emergency, we want to first see if the patient has suicidal thoughts or ideations, or if they have homicidal thoughts or ideations. If the patient has suicidal thoughts or homicidal thoughts, they need to be transported to the hospital. They, at that point, cannot refuse. It's very important for their safety for them to not stay at the house. Also important for your safety and the others around them. So it's very important for them to go to the hospital. We always want to try to de-escalate the situation. We want them to feel safe. They're already upset. They already feel alone. We do not want to do anything to make them not trust us more. So what we try to do is we want to de-escalate the situation. If we cannot de-escalate the situation and the patient is still refusing to go, if they have indicated suicidal thoughts or homicidal thoughts, again, they have to go by law. So we can take the means that are in our protocol. We have medications to give medication restraints. So we would give First Aid, which is midazolam. Our dose is 2.5 to 5 milligrams, and you can repeat to a max of 10 milligrams. Now, if they have an elevated BAR score, which is behavioral score, if it's elevated, you can go ahead now in our protocol and give 10 milligrams, and that would be intramuscular. So again, we want to try to de-escalate. We don't want to try to get to that point. However, for the patient safety, they cannot stay at home if they have attempted suicide or have proved thoughts of suicide with a plan, because we need to get them to the hospital. We need to get them that treatment started, and they do not need to stay alone where they could possibly hurt themselves. So we can give them the medication. Other than chemical restraints, we also have physical restraints that's also for the patient's safety. So we have soft restraints. Again, everybody's protocol is different. I know with our protocol, we make sure that we fasten the restraints to an immovable part of the stretcher. We do not want to put it on the rails because we don't want them to be able to break off the rails and it to be something that could harm them or us. We don't want it to be on the wheels because we don't want it to get caught for obvious reasons. We also want to make sure that we're checking pulse, motor, and sensory as soon as the restraint is applied. We also want to make sure that we reassess the patient. We're taking vital signs. We're putting them on the cardiac monitor. And again, that's our chemical and our mechanical or physical restraints that we would give. So if a patient is chemically restrained, they do not have to be physically restrained unless they are still a danger of possibly harming themselves or somebody else. And then we would go ahead and do the physical restraints as well. Now, if you physically restrain the patient first, they do have to be chemically restrained because you don't want them to be fighting and to end up harming themselves more. So you want to give them that medication to help calm them, and then that way you can put them on the cardiac monitor, check their vital signs, and continue to keep a check on them. We also want to put them on capnography, assess their breathing. Another thing that we would look for is signs of excited delirium. I know we didn't talk about excited delirium in our PowerPoint. That is not actually a mental illness. However, it's something that's caused by the mental illnesses. So the excited delirium is a confused, hyperactive state that the patient would be in. They would be super strong. It's almost like super strength. We look for increased heart rate. We look for increased blood pressure. We look for them to be very confused, altered, sweating, very hot. So we're looking to see if the patient is red in color, if they have a elevated temperature, if their heart rate, if they're in sinus tach, their heart rate's 140, 150. We want to check those things. That would make us really think that they would possibly be in excited delirium. And that's a very serious condition. And again, it can stem from mental illnesses. It can also stem from substance abuse. And again, like I said, when the substance abuse and the mental illnesses are combined, that's when we see a lot of these patients. So again, our state protocols and our local protocols all may vary a little bit, but for our agency, our protocol is to give ketamine. We give ketamine 400 milligrams. You can give 200 milligrams in each bicep, or you can give it in the glute. If you give it in the glute, you can give 400 at a time. So you could do 200 and 200 in each arm, or you can do 400 in the glute, and that would be intramuscular. You also want to make sure, again, you are reassessing these patients. We also want to make sure that we try to get 2 large bore IVs, so preferably bilateral 18 gauges would be awesome. We also want to make sure that we restrain these patients, we check their temperature, and we give fluids. So fluid boluses are also recommended. So this about wraps it up. I just want to appreciate you guys for hanging in there with me, and I just really hope that you learned something today. Thank y'all so much. Have a great night.